Okay, welcome to part 2 of the level 1 MRI training. Um, First, I'll start with the policy of gowning. So generally speaking, gowning is required of any participant that will be scanned in the MR. And this is without many exceptions. However, it is possible that there is an anxious or depressed population which requires special exception in order to ensure that we are not excluding that population entirely, and that would require a discussion with the research director, Dr. Bray. Um, and how we go about this policy is to provide child pajamas or adult scrubs, depending on the size of the subject. And these are available in a washroom that I'll show you during the demo, which is just outside the MR double doors. Um, we have relaxed the policy somewhat such that it is permissible to substitute cotton sweatpants and t-shirt, but we require that these are brought in and not worn in from the street. And that's so that they can be inspected and we can shake them out and ensure that there's no objects that are being forgotten that are still in those clothing. It's important to note that we don't like to see non-cotton clothing because some of these synthetic materials, particularly in athletic wear, actually have been found to cause burns, especially when they're both tight and having some of these synthetic materials. So in particular, yoga pants, not allowed. Generally speaking, we ask the subject to put their street clothing into a locker. This is likely to change with COVID-19, but I'll be giving an update regarding special procedures for the COVID-19 phases in a separate video. If a guardian is going into the MR scan room, they must agree to be wand screened if the operator or level 2 says that they would need to be screened this way. So this is an optional step that is at the discretion of the operator, whether or not they think that a guardian needs to be wand screened. And this is because the fact that we do not allow, we do not require the guardians to be gowned, because although we would like to screen them and we would like to prevent any ferromagnetic materials going in, they are not going into the MR bore, so therefore the risk is considerably lower. However, in those circumstances where perhaps we see a bulge in a pocket and the guardian or parent is not forthcoming about what they have there and then why they're not taking it out, then perhaps we would screen it with a wand. Generally, it's also to find whether or not certain items are metallic when it's not really obvious from visual inspection. Regardless of gowning, both with the participant and the guardian, we should always be visually screening. And I like to doubly emphasize this because even level 1 and other MR staff can occasionally forget that they have necklace or a bobby pin or perhaps some item in their pocket which they should have remembered to take out before they enter the scan room. So always remember to visually screen. So moving on to one of the main risks associated with the MR, it's that we have a very large magnetic field. And if you imagine the cylindrical shape of the bore, that's like a large solenoid magnet, which can in fact pull objects into the bore, or that is the center of the MR. And as indicated and discussed at length in the level 0, it is possible for an object to fly into the bore, and non-intuitively sometimes larger amounts of metal can actually move and be affected by more force than small amounts of metal. So that projectile effect can certainly cause lethal injuries if it was to be a large enough item that crushed someone in the bore. Less well known are the fact that there are torque effects, and these can affect things like an implant or other objects like shrapnel that are inside the body, and that rotation or turning of the implant can, in fact, either make it ineffective or even cause injury to the person. So that's another reason why we have to screen people. Also, another issue to be aware of with the main magnetic field is that even though we have some equipment in the room, which one would think is safe, it could be MR conditional, which means that it is safe up to a certain point, typically the 5 Gauss line, before it is no longer warranted to be safe. And that could be because it actually can be drawn into the bore to some extent, probably much less than you would think, but nevertheless, having some magnetic or electronic components, and those electronic components might actually be damaged by the field if it becomes too close. So make no assumptions about what is safe and what is not safe if you don't know. Another checklist item on our initial SMART list is the acoustic protection and monitoring. And so there's really 2 points here that the developers of this list were trying to get across. One is that we have to be sure that we're protecting the hearing of the participant as well as anyone else in the room. For example, in the case of the guardian, we would want to always have them with earplugs or hearing protection of some kind. And that's even though they're outside of the bore where it's not going to be as loud, but the scanner does make quite a lot of noise, and exposure to large amounts of this noise for an extended period of time could certainly damage your hearing to some extent. The participant has a special headset that not only protects it from noise, but also is used to communicate, to be able to hear the operator and talk back to the operator. This works well when the scanning is not taking place, but under circumstances where the scanning is going on, and particularly loud sequence, then it may not be adequate. In other words, we want to have a secondary system for communicating, and that is the squeeze bulb, which is shown in the picture here in the hand of the participant. And sometimes this is given to the guardian in the case of small children in particular. And the purpose is to just quickly indicate that there's something that is making the participant very uncomfortable. We don't want people squeezing it all the time, of course, but on the other hand, it shouldn't be thought of as being only for dire emergency situations. It can also be used just to indicate that the subject needs to take a break. Visual monitoring should also be remembered here, because even though we expect that the squeeze bulb and the headset will be adequate, it's also possible that the subject is trying to get attention by, say, wiggling or moving their feet or waving. So definitely both the operator and the level 1 should keep an eye on the subject for nonverbal signs that they need assistance. Another source of potential risk that is perhaps lesser known and understood by people that are just coming into the MR field is that both the RF pulse, which is called the B1 field, as well as the gradient switching, can cause a changing magnetic field that is also potentially going to cause a changing electric field. And because human tissue can conduct, it's possible that that changing electric field causes a current in the human tissue. Now, although one should not be overly concerned that this is a risk at all times, it is something that does occur. And in fact, this kind of current, if the conditions are exactly right, can cause burns. And what sometimes surprises people is that the most commonly reported patient event or that requires medical assistance in the MR area are burns. And these are because of the RF field or the gradient switching, which somehow interacts with the subject plus the equipment plus in order for that to happen. So I won't get into the MR physics very much, but just so that you understand the terms, gradients are used in order to change the magnetic field across the patient's body in order to be able to localize the signal. And during the course of scanning, the pulse sequence requires that the gradients are switched in magnitude and direction many times, and that's where the changing magnetic field comes from. And the other source of changing magnetic field is the pulse. So when we put energy into the subject, we use an RF field, and that automatically will cause a changing magnetic field seen at any particular point in the subject's body. One of the reasons why this can cause a problem is because of loops that are not predicted by the modeling that is done in order to make MR safe. And so those loops could be cables in the case especially of clinical procedures, but we also want to avoid body loops, which are, for example, caused by hands being crossed, legs being crossed, and touching of the body to the bore or to the head coil. So we use padding in order to avoid that. Finally, another issue with respect to the B1 field is that you are putting energy into the subject, which is going to be absorbed by the tissue. And although the scanner calibrates such that there is not too much energy, that it heats up the tissue too much, that calibration requires an accurate participant weight. And so that's why we emphasize that that has to be filled in correctly on the screening form. Just a little bit of additional information about the MR training levels, which of course was the T checklist item on our SMART list. You all know now that the basic training is level 0. What should be also clear to you is that that allows a person to be able to go into basically any of the areas between the outside hallway up to and including the console room, but not inside the MR room. In order to be able to go inside the MR room, we require at least level 1. And that's because presumably you also have a better idea of what equipment is in there and how to use it correctly, and also how to assist with scanning. Level 2 is usually reserved only for a small number of researchers, and those are people that will be required to operate the 3T, particularly at off hours, and it's much, much more training than what I'm doing here with level 1. And finally, it should be noted that part of ensuring that we keep a safe environment is that your training level, not only level 1 or 2, but also level 0, should be refreshed on an annual basis. So I will be coming back to you and asking you to take the refresher seminar. And if you've been away too long, then your training has lapsed and you'll have to take the training again as if you had not been previously trained. I mentioned zones 1 to 4. Quick orientation so that you understand where those are in our hospital. The main reception area, which connects to the main hallway in the hospital, is shown at left here. That's zone 1. And once you go through the doors into the inner hallway, then that's zone 2. And as shown here, there's a small waiting room beside the gowning and washroom area, but exactly where people will have to wait will be updated in the COVID update in order to indicate the new requirements in order to make sure that we don't have overlap. You can see the 2 red bars which are indicating the outer MR doors. The one at the top is the one I would like you to enter the area through. This brings you very close to our console room and our GEMR, which is what I'm showing as zone 4 here. There's actually a second magnet close by, but that's for the clinical use only. So I've talked about quite a few policies already, but I'll mention a few others, which we call the standard operating procedures because they're policies specific to our center and should also be followed. And the first one is that we want to have 2 trained people at the MR for all scanning activities. The operator, of course, the one that's running the scanner, touching the console, using the controls on the MR equipment itself. And this one could be a level 2 researcher, or it could be an MR technologist who has more experience with clinical. The experimenter is either a level 1 or level 2 trained person, and this person is there to ensure that the scanning, to the best of their ability, achieves the objectives of the study. And this could include asking the operator to rescan a particular sequence if they think they absolutely need that sequence more, or perhaps cutting a sequence or rearranging the order of the sequences, and perhaps going in and talking to the child. Any of these activities are typical of what a level 1 might do in order to be able to help ensure that the data is collected properly. They were also in charge of, for example, setting up the stimulus computer, which can be used for fMRI particularly, or logging what happened during the scan that was good or bad with that subject. Second procedure I want to mention is crowd control. We really don't want to have a huge group of people going into the console area, because then it becomes very difficult to ensure that no one breaks any of the policies or goes where they're not supposed to go or presses a button, which children especially like to do. So try to ensure that there's only a guardian and 1 subject that's entering the area, and not, for example, a large family. The others can be perhaps permitted to wait in the waiting area, or if that's not feasible because it's other children, then they might go to a playground area that's available within the hospital. Of course, we don't want children to be running loose because some equipment is quite sensitive, as I'll talk about later. And fourth, it's important not to move around equipment in the scan room. I mentioned briefly about MR conditional equipment, but generally speaking, if you haven't been trained on equipment, don't move it. You wouldn't want to be damaging someone else's experiment, even if it's not a safety issue. So just assume that you're not allowed to move any equipment in the scan room. The next area I'll talk about is consent. And consent is basically an agreement that is made between the study scientist and the ethics board about what procedures will take place in your study. And so therefore, each consent form is individual, and the details certainly can change between them. And I would encourage you strongly to discuss the consent form for your study with the scientist to make sure that you understand the details. So I'll just touch on what I consider to be the highlights that are common across consent forms to ensure that you understand the basics. Of course, consent has to be voluntary. That means that there should be no suggestion that the subject is in some way being coerced into doing the scan, either by a parent or by one of the other researchers. What's perhaps less obvious is that consent can be withdrawn after it's already been given through a science form. So that means that perhaps someone has a bad experience, they get upset during the scanning, and they'd like to leave and go home, and they do not want you to use the data. That's fine, and that's something that you should be aware that you're not somehow coercing them into staying when they clearly don't want to. With children, it's a bit of a fine line. Definitely, crying child is not something that we want to see, so therefore I would say that's definitely not a consenting participant. But it's certainly permissible for a level 1 or a parent to take a moment to talk to the child to see whether or not perhaps they just need a little bit of rest before they continue. Number 3, consent can be withdrawn at any time, and this includes the possibility that months later they decide that they don't like the idea of being part of this study and they can withdraw their data, even though the time of the scan was long past. And finally, we have to make sure that we provide full disclosure, and what that boils down to is ensuring that they've taken the time to read it and not rush through it, and that the consenting process touches on the highlights of the consent form. Now, since we have a children's hospital and most of our participants are children of a relatively young age, it is sometimes the case that a study will have an assent form if they're able to read. And this is a simplified version of the regular consent form that the guardian will sign. And it has to be emphasized that for any minor, the guardian will always sign their own consent form, but some studies will also require an assent form as well. Be sure to give the participants a good amount of time to read and understand the form, and the best way to ensure that this happens is actually going through point by point the consent form, not reading it word for word to them, but making sure that they get it. And one way that I think you can understand why I emphasize this is because not everyone is as literate as you might expect coming from a college educated background. And second, there are many people that are very busy and they have time pressure and they're thinking of the next thing they want to do. And as a result, they skim to an extent that it's not really consent. So what do we do with the consent? It's kept by the scientist because it's part of their proof to the ethics board that the procedures have been followed. But we do want a photocopy of the signature page. And we don't need all the rest of it, just the signature page to ensure that the procedures have been followed. Okay, another common topic that comes up is the photos that are very popular now for both subjects and guardians to want to take. And we have a few concerns here that we try to address with this policy. And the first is that we don't want random people snapping random photos all throughout the area. So we should insist on staff, including level 1s, taking the photos. And One reason is we do not want the camera to be destroyed or go into the MR room. So, but we can take a picture through the door so that they can see, the inside of the MR room and that the participant on the table or something like that. We don't want pictures taken of the console area unless it is very, very carefully screened. So generally just no photos in the console area, because nowadays with high resolution cameras, they might pick up some confidential information that is posted somewhere in that area. We also don't want to have photos taken without verbal consent. So imagine you're a technologist and you're having a bad day. You don't particularly want someone taking a picture of your face and posting it on social media. So ensure that everyone in the photo has verbally consented. And finally, one of the reasons why people want a photo is just to get a snap of their brain from the scanner console. And we would much prefer that this is obtained later in a controlled way, either by the level 1 or perhaps with assistance from me or someone else, because otherwise, very easily, someone could snap something which is sensitive. There is patient information on the scanner console, and it might be the full name, etc. Now, there are separate guidelines for staff researchers who want to do photography for professional reasons, like putting it on the group website, etc. Just know that there's a special consent forms from both ACH and U of C for this type of thing, and you would want to look at the care handbook to see how to do that properly. Okay, moving on to an important issue for level 1s to learn, and that is that there is a specific documented procedure for how to deal with subjects who seem to need medical assistance. And I say seem because you may have to follow this even if you don't think that they are in terrible distress, but you want to be sure that they're getting the help they need, that you are not qualified to give. For example, any kind of first aid that you think is needed should be given by trained staff, not by a level 1 researcher. Okay, so we have this patient event procedure flowchart, which is correct, and it's on our console wall for easy reference, especially if you forget. But I'd like to simplify it down to something a little bit more linear, and this basically gives you the highlights of that you absolutely need to know. There are 2 types of codes that might be called, and these are called on a regular phone that you can find on the desk of the console area. A code blue basically means that you think the subject is having a life-threatening event. Imagine they're having a heart attack, they don't seem to be able to breathe properly, they're having a seizure. If you think at all that it's possible that this is life-threatening, you should call code blue. And the procedure for doing this is that the operator would manually pull the table out of the bore, they'd undock the table, they'd move the patient to the recovery area, and the level 1 would do the points in yellow, which are they would close the MRI room door and they would call the code. And they do this in a particular way. They dial 600 and they say code blue MRI, pediatric diagnostic imaging, main floor. Unless, of course, it's an adult, in which case you indicate adult. Then both of you would follow the instructions from the code team. So in essence, the operator is the one that's responsible. They're the one that should take over. However, what they should be telling the level 1 to do is exactly what I've shown in yellow. Call the code, close the MRI room door after the subject is being moved out of the room, because we don't want first responders going into the MRI room. Even though they should know better, when there's all kinds of warning labels on the door, we can't assume that first responders will not go into the MR room improperly and bring in some equipment that is not safe for the MR room. Now, the second kind of code that we are concerned with is code 50, and that's basically anything else that requires medical assistance. So imagine someone has fallen off the table and bumped their head. You don't think it's life-threatening, but you think maybe they need a nurse to look at them. That'd be a good enough reason to call a code 50. Everything else is pretty much the same, except that you don't really need to specify whether it's an adult or a pediatric case because it won't really matter. Okay. Now, another area of policy that we want to make sure you're aware of is incidental findings. Incidental findings means that the researcher has seen something on the brain scan that concerns them, that this person might actually have some sort of pathology that they need to be aware of. And so we have a very clear policy about how to deal with this because we want to make sure to balance their right to know with other concerns, particularly legal concerns and concerns about ethics and privacy. The whole thing is described in the care handbook in detail, but what I want you to remember is that you should not be alarming the subject about this. What you should be doing is informing the scientist, the study PI, about it, who would then take it to the next step if they deem it necessary. And an alternative acceptable option is to discuss it with a technologist, which is available around the console area. In other words, if this happens while scanning is taking place, then you could just go over and bring a technologist to the console and see what they think. That would then maybe determine what the next step is. But what you should not do is immediately talk to the scan subject about it and alarm them, because it might be something that they already know about, but would embarrass them, or it might be something that you're completely wrong about, and we don't want to cause them undue anxiety. Okay, a few technical notes about patient registration. The first is that there's a few things that a level 1 should know in order to help the operator do their job. If it's a tech in particular, they may not know anything about your study. This may be the first time they see it, and therefore you need to make sure that they're getting the right information here. And that includes scan ID, which means like a code for that subject, and how it's supposed to be written into the registration. This is something that should be part of your protocol and should be explained to you by the study lead. You have to make sure that the correct patient weight goes into this form, and I mentioned before why that is. And you have to, of course, know the correct short code or node name, as it's known, for the exam description field. And this is so that it can be pushed properly to the archive, which we call the research packs. I put 3 question marks on here for things which may need to be filled in, but it's study specific. That's date of birth, age, and sex. These demographics are typically not collected, but some studies do. So you should know that when you are helping out with an exam. Afterward, after the scanning is done, there's a couple things you should be checking. One is that you want to make sure that the operator does push your study to the archive. The protocol determines whether it's pushed to just the node for that particular study, or perhaps to also a backup like the GE-MRAW. And you or perhaps somebody else on your team is supposed to be checking that these were transferred correctly within 1 week of the scan. This is something that goes out in a quality control email to certain people in the study. And the reason for that is because we do eventually have to delete scans off the console. It's not a huge hard drive on it. And we also want to make sure that nothing went wrong during the transfer. And that's kind of your job to make sure that any problem associated with transfer is at least known about, and then you can contact me. And of course, there's no absolute guarantee that this computer will not crash. If it did crash, you know, 2 weeks afterward, you'd be kicking yourself that you didn't make sure that your data was saved. So please check fairly soon. The big red buttons are safety buttons that are in the MR area. You actually are not supposed to be pressing any of these except in very unusual circumstances where the operator is not at all able to do their job. And there's no techs around, and basically, you know, everything is up to you. That would be unlikely, but I want to make sure that you know about it, because hopefully you can help make good decisions if there was an emergency by helping a level 2 or a standing guard against someone doing the wrong thing. So the first and most important is the quench button. This is shown on the white box that is in the top picture. It's a red button under a plastic cover, and it's in the MR room. And basically, if you press it, you're destroying the MRI. So you can imagine probably a $100,000 mistake, which would also mess up longitudinal studies, and generally everyone in the department would be mad at the person pressing it unless they were using it in the very unusual circumstance where it's required. And that is if there's a life-threatening situation when a person is pinned in the MR by a metal object. So imagine a table has gone in and is pinning someone in the MR. That's about one of the few situations where I could imagine pressing the quench button. So don't press it. And also, probably you should be preventing anyone else from pressing it unless they really know what they're doing. Second emergency button would more likely be used, but I've never used it, and no one I know here at Children's Hospital has used it, and that is the emergency power off. It's used in order to be able to cut the power to the MR room. For example, in a fire or flood situation where you think someone might get electrocuted. If, you know, smoke was coming out of the MR, you know, water was raining down from the ceiling, that might be a reason to press it. Otherwise, please protect it from being pressed. Finally, there's an emergency door opener beside all of the MR doors. Basically, that's to prevent, it's used in order to be able to release the pressure on the MR door. I won't get into why that's needed, but just be aware that although it's not terribly damaging if it's pressed, I'd rather you did not, because it's only used if someone is not able to get out of the MR room. Okay. That completes all I want to talk about in this video. There is still an MR area demonstration to come where you tour the MR area, familiarize yourself with the layout and the technology, and to learn the manual patient event procedure, which I described a little bit earlier. So your next steps are, after finishing this video, is to take the level 1 quiz that we'll give you a link for, and then sign up for the next opportunity to do the demo. And in order to make sure that you obtain your level 1 status, you need to submit your completed signed level 1 form to Vanessa, who will ensure you also get MR area card access so that you can get through those double doors I mentioned. And thank you very much for your attention. You can receive the slides from us, and I hope to see you at the demo. Thank you.